Thanks for having me, everybody, today. I'm Rebecca Bridges. I'm a pediatric neuropsychologist at St. Luke's Children's, and so I get to just share knowledge about neuropsychology with you guys. And we should have some time for questions at the end. I love questions and discussion, so I'll kind of go through all of this first. You guys can pop questions in the chat, and then we should have some time at the end, too, for any other questions. All right, so you can go to the next slide. So my learning objectives for this talk today, I'm hoping that attendees will be able to differentiate what a neuropsychological evaluation is versus an autism evaluation versus psychological testing services, and maybe some of the overlap that they have at times. That attendees will be able to describe at least 2 areas assessed within a neuropsychological evaluation, as well as be able to describe at least 2 specific referral reasons which may be appropriate for neuropsychology specifically. Next slide. So who is a neuropsychologist? They are a doctoral level psychologist with a degree in psychology. So it might be a PhD, it might be a PsyD like myself. And after you complete your degree and your required internship, then you have to do a specialized 2-year fellowship in neuropsychology specifically, with at least a greater than 50% focus in neuropsychology. And then within that, there are other subspecialty areas within neuropsychology as well. So you might be a pediatric neuropsychologist like myself. You could be an adult or geriatric neuropsychologist who focuses on, those neurodegenerative conditions, diagnosing dementias, those types of things. You could be a lifespan psychologist that does see children and adults. Or a forensic neuropsychologist who works in forensic settings. So there's lots of different subspecialties within neuropsychology as well. Next slide. So what does a neuropsychologist do exactly? We specialize in cognitive testing that assesses the integrity of brain behavior relationships and the impact on all areas of functioning. So what does it look like? When parents come in to see me, they say, are you going to put my kid in a scanner? Are you going to put a cap on their head and measure their brain waves like their EEG? Our testing's a little bit different from that. Testing's a lot like the testing they might do at school with a teacher. So it's paper and pencil testing, or verbal and nonverbal tests that are administered in a one-on-one environment. And these tests give us standardized scores to let us know where those skills might fall for the child in relation to same-aged peers. So compared to other 8-year-olds or 9-year-olds or 10-year-olds, where are they falling in that skill? Are they solidly average or above average? Or perhaps are they below age and developmental expectations, and do they have some skills falling within the borderline or impaired ranges, which would make us concerned for that skill? Neuropsychologists specifically are trained to look at pattern of scores. So it might not just be one specific skill that's low, but it could be a specific pattern of the scores that we're seeing. And we also really heavily rely on the qualitative information that we gain in our evaluation, as well as the history from parents. And we kind of integrate all of that together to come to our summary and impressions. So the tests specifically that I might give, would look at things like intellectual abilities, executive functioning skills, speech or motor skills, visual spatial skills, maybe attention and memory. We might also look at mood, behavior, social skills, those types of things. And neuropsychological testing specifically is really useful in predicting outcomes for education, for behavior, for social functioning, to an extent that our other diagnostic indicators might not be able to, such as looking at an MRI or CT scan, those types of things. Next slide. So what are the goals of the neuropsychological evaluation? We really want to document the impact of an individual's medical condition on their cognitive or their psychosocial functioning. Within our evaluation, we want to describe a pattern of strengths and weaknesses for the individual. We might be able to detect subtle cognitive changes after certain medical interventions or treatments. We can track cognitive functioning over time. For certain children with certain conditions or medical treatments, we might not see their deficits until later on. They can kind of grow into their deficits, so we might want to follow them over time. We can assist in recommendations for school reentry after an injury or an illness. And our findings are really helpful in designing interventions for kids to positively impact their functioning, maximize their functional capacity, and overall improve quality of life. Next slide. And so the setting of the neuropsychologist matters as well. So in hospital or medical settings like where I'm at, a neuropsychological evaluation referral requires the individual to have a qualifying medical condition for it to be medically necessary. There are outpatient neuropsychologists that work in private practice that might not necessarily specialize in medical conditions, and they might do other types of testing like assessing for ADHD or autism or learning disabilities. Learning disabilities specifically are not covered by medical insurance, so that's often not provided by hospital-based providers. So if families are not able to get that type of testing through the school, they usually have to pay that out of pocket with a private practice psychologist. And then in the hospital setting, a neuropsychologist might also serve different roles in terms of maybe doing brief evaluations for children who are inpatient. They might work in rehabilitation settings with a rehab team, or they might take on consultant roles in multidisciplinary clinics like spina bifida clinic, craniofacial, those types of things. Next slide. And so I kind of described what it is that we do in testing and what we might measure. But neuropsychologists are really good at confusing people and talking in this lingo that a lot of people don't understand. So I wanted to try to give a really tangible example of what my results might mean, or an example of kind of my summary or impressions. So let's say that there's a parent of a child who has NF1, and they say that their child has memory problems. And at home, when they tell them to do something, they just can never remember to do it. They might go to school and then come home and they can't even remember what they did that day. Their MRI was unremarkable. Their ophthalmology evaluations have been fine. So that leaves the medical provider and parent going, what the heck is up with these memory problems? So they might send them to a neuropsychologist. And what I might find on my testing is that the functioning of the learning and memory systems of the brain are actually appropriate and intact when we think about the hippocampus and the temporal lobe in general. But my testing could show that the child is having retrieval deficits. So they can get the information in just fine. They can store it over time. But when someone asks them to recall it or retrieve it off the top of their brain, that's where the issue is happening. And that's actually not an issue with the temporal lobes. That's more suggestive of frontal lobe dysfunction or executive deficits. So my recommendations for intervention for a child with a retrieval memory deficit would be much different if they had a true encoding or storage issue, or if they had truly amnestic properties. So testing like this could really clarify where the issue is coming from and what recommendation or intervention we might need to do. Next slide. So one other example, let's say there's a parent of a child who has PKU and they're complaining of learning challenges. Their child has been really slow to develop their academic skills. They're really struggling in reading and spelling and math, and in all areas, they're just having a hard time. They're spending hours at home doing homework, but they got testing through the school and they didn't qualify for an IEP under a learning disability category. So sending them to neuropsychological testing could be really helpful, because what I might find is that they might actually have a processing speed deficit. So, and the etiology is likely related to their PKU. High PKU levels are toxic to the brain. It mostly impacts the white matter tracts of the brain, which are important for processing speed. So that means their interventions or recommendations should be for slow processing, not for a learning disability. Next slide. Okay, now touching on psychological evaluations. This might be completed by a clinical psychologist who would want to complete testing for diagnostic clarity or for treatment planning. So they might give more of an abbreviated battery that looks at things like IQ, attention, personality, mood, and behavior. Reasons for this type of testing might be for the psychologist to help differentiate between diagnoses of, is this PTSD or is this anxiety? Is this depression or is this ADHD? And this could also be differentiated from a psychiatric evaluation, which would come from a psychiatrist, which is a specialized diagnostic interview by a psychiatrist. But at times, sometimes both of those things might be needed together, especially if there's concerns for maybe a psychotic disorder or a personality disorder. A psychiatrist and a psychologist might work together to both do evaluations to help with diagnostic clarity. Next slide. Now touching on autism diagnostics, I think the one question that I get for families when they come in is, I don't know what's really going on with my kid. Can you test for everything? I want to know anything that they have, test for everything. And unfortunately, we can't do that. It would take so much time, and it doesn't make sense to test for everything either. If you saw our diagnostic manual, it's like this big. It'd be impossible to test for everything. Just like any other medical provider, we would tailor our testing battery or things that we order or do based on the referral reason, the child's developmental or medical history, their treatment needs, those types of things. So when families have a question of autism, this can be really different based on the setting and your area. So in some hospitals, there might be a separate autism diagnostics clinic and then a separate neuropsychological clinic. In some hospitals, they might be merged together, and some hospitals might not even have access to either one and might be more of community providers, either clinical psychologists that do the testing. In the rare cases, like our own lovely Dr. Elena Harlan Druhl, there can be a neuropsychologist that also specializes in autism diagnostics. So having one of those is awesome because they really understand the impact of the child's medical condition on brain and behavior, and being able to differentiate that in terms of the autism symptoms as well. So it's just really important to know your local providers and your psychologists in the area to know what their specialties are, because not all psychologists are trained in autism diagnostics. So it's important to know if they have the experience and the tools to be able to test for it. That way they can answer those specific referral reasons for you. Next slide. All right, so take-home messages and key points. So putting in the correct referral or order is really essential to help families get to where they need to go. So neuropsychologists in general are really happy to help consult and give guidance on what type of testing they might need. It's really confusing to understand the difference between psychological versus neuropsychological, et cetera, those types of testing. So we are always happy to consult and give guidance when needed. And as aforementioned, it's really important to know your referral sources and their specialties to know if they can answer specific referral questions for you, or if a child might need more than one evaluation from different providers to be able to answer all the questions that you might have. And then last one, sending a clear and specific referral question is really helpful. One, to make sure that they get to the right place. But two, also because neuropsychologists, our reports are so lengthy, and I don't think they're ever going to get shorter. But it's because we write for multiple audiences. So our reports go to the families, they go to the schools, and they go to the referring providers as well. Families only have 1 hour with us to go over all of the results and talk about all the neurocognitive data. So we tend to write pretty lengthy, detailed summaries. That way, when families go home later, they've kind of started to process everything. They can refer back to our report for all of that important information that we talked about. And then for the school, they're not a part of our feedback session, so we have to be pretty detailed in what we think, what's going on diagnostically or in the cognitive profile to help the school with their accommodations or recommendations or those types of things. And so when there's a really clear, specific referral reason from a medical provider, it's helpful for neuropsychologists because we can do specific things to give you quicker answers to your questions. So as a medical provider, you don't need to read our whole summary. You already know the child's whole history. You already know what IQ and attention mean, all of those things. So neuropsychologists might be able to tailor their reports for a specific area, like putting a couple of bullet points at the top of the report that you can really easily refer to get your questions answered. Or some neuropsychologists have the practice of writing brief letters to the referral sources or calling them on the phone. So if they know exactly the question that you're wanting to know an answer to, it can make our ability to relay that information much quicker and easier to you. So that way you don't have to read the whole 12-page report. All right. And I don't have a lot of references because I didn't really talk about any journal articles or anything specific. I've just got some information here about the APA and clinical neuropsychology.
Wow, thank you, Rebecca. That was amazing. I think that all of us have had the neuropsychologist in a box of magic. And so, I'd love to see any questions that you have in the chat. If you want to write your questions there, that'd be great. As questions start to come in, I would love to know what we can do. Lots of families come in asking for memory testing. Mm-hmm. Can you speak on that just a bit?
Mm-hmm. Like, do you want to know like what the memory testing is, or if it would be appropriate to refer them, or?
We help you know what to do. Like, I had a kid today that is forgetting only in the context of his mom. And there's a kind of stuff. So the true memory deficit, I love the idea that you were talking about earlier about memory retrieval. Mm-hmm. What can we do that helps us sort out memory problems, which is a common complaint?
Mm-hmm. Yeah, it is a really common complaint, which is why I kind of brought it up. It's common in a lot of conditions that might have executive functioning issues, especially like kids with ADHD will have those types of memory retrieval difficulties. So really talking with parents about like, what types of memories do you think they're forgetting? If you give them a cue, does it get better? That can kind of let you know if it's a retrieval deficit of, okay, I told you to do 3 things earlier. Was it to clean your bed? Was it to take out the laundry or take out the trash or things like that? So giving them cues will really help you know if it's a retrieval deficit versus an issue with like encoding and storage. And I think just kind of basic conversations with the kid, if they do have some true honest to goodness memory difficulties, you could see it probably pretty easily just in your conversations in terms of what they're remembering, what they're not remembering. Do they remember their teachers' names, their friends' names, those types of things that you know that they should remember for their age.
Yeah, great. Thank you. Let's see. We have Dr. Susky for my older patients with autism diagnosis as they enter high school. Is there a role for a neuropsych eval to help them plan for future plans like jobs, trade training, independent living, life skills like handling the need for supervision and those life skills?
Mm-hmm. There are some neuropsychologists that serve a role for that. We kind of call that like a transition evaluation. It might be a neuropsychologist, but it also might be just a clinical psychologist who specializes in kids with autism. So again, just really helpful to know who your referral sources are. But there are psychologists that definitely do those types of evaluations to try to understand where their basic cognitive skills are, where are their independent living skills. In neuropsych specific, we have a few tests that can pull for independent living skills in terms of, can they manage or understand basic money, time, calendars, those types of things. And then Dr. Drool said yes. And then usually those supports will also be included in transition evaluations through like an IEP in school as well. They usually start transition planning around 16. And then they might pull in other community supports like vocational rehabilitation or those types of things to help them get ready for their launch.
And what about neurotypical children who go into adulthood? Um,
I would say probably as well. From a neuropsych perspective, that might be more for the kids with qualifying medical conditions. We always try to see them before they turn 18 to do any kind of adult planning for them. But for other neurotypical kids who might have ADHD and might be really forgetful in their daily activities, those types of things, either working with a psychologist long term to do some intervention to build those types of executive functioning skills can be helpful, or going through an evaluation to see where their independent skills are at could also be helpful.
yeah, thank you. That's super helpful. What other questions do people have?
I think Travis has his hand up.
I do, Dr. Bridges. Thank you. What about the 3 year, like I get my kid and I have a counselor, right? I have a kiddo and they get a neuropsych eval. And then I'm like, all right, parents, every 3 years, you need to go get another neuropsych eval. And you do it every 3 years until you turn an adult. Is that true? Is that false? What's the
Mhm.
rotation there?
Great question. It actually varies from child to child and based on kind of their medical condition and what do we expect for their neurocognitive profile. I typically don't recommend an evaluation every 3 years. From the school standpoint, they will do the eligibility report updates every 3 years to look at IQ and academics, and that's very, very helpful for academic planning. But from a neuropsychological evaluation in our reports, we will typically give a very specific time frame recommendation of when we would want to see the family again. And it varies because I see kids who have, life limiting conditions, and it might not make sense to continue to expose parents to this type of evaluation over and over. For kids like with NF1, their cognitive profile can stay pretty stable, so I don't need to see them a lot unless there's more cognitive concerns at transitional points, like they get to middle school and things are just kind of going awry, and we want to take a look at things again, or they transition to high school and there's so much more independence and they can't keep up. Maybe we'll do another evaluation. But then there's other conditions where we do want to follow more closely, like my brain tumor kids after they've had radiation and those types of things. I followed them more closely than some of my other kids just because of the late effects of radiation that we might see.
Would we, um, like if we get a kiddo that I get some of my adolescents and they get concussions quite often, or they can, and would we have, if they've already gone through a clinic and worked through, would we look to have them continue to see a neuropsych or send a referral back to a neuropsych as they move forward, even if their symptoms don't, like there's no symptoms concurrently occurring?
Yeah, great question. Generally not. Kids who might have a concussion generally don't usually need neuropsychological evaluations. The research indicates it's best for them to be served like on a concussion team short term, and then they can work with a neuropsychologist for short term for any reentry to school types of things. Unless they have like a moderate to severe traumatic brain injury, then they would need to be followed more closely over time. But for any kind of, those lingering post concussive symptoms, those are best managed by like intervention, psychotherapy versus neuropsychological testing. All right.
Think
Any other questions?
other questions?
I wanted to mention something. Rebecca, thank you so much. I had invited a member of our team here at St. Luke's to present, and Rebecca, you did a fabulous job. Thank you for representing neuropsychology, and I think you probably answered some of the questions better than I would have. I do a lot of autism evaluations. That's probably why, and so sometimes I'm not as in the weeds regarding medical diagnoses. But one thing, Travis, also to answer your question as it relates to children with autism, because this might be kind of, since this is kind of the theme of the echo. I don't recommend every 3 year evaluations for autism spectrum disorders. I don't necessarily think there's going to be there's not a progressive nature to autism like there would be for, say, some neurodegenerative diseases or inflammatory diseases or things that need close monitoring, or kids who might grow into their deficits, like Rebecca was saying. So there's no need to really have those serial assessments. But I always tell my families, I want to see your child at 17. to help with that transition planning. If something comes up between now and then, I can always serve as a consultant. I can always do an evaluation. Like if there's education is going down the tubes and they don't know why, or they are developing some comorbid mental health issues that are really causing issues. So there's always a reason. There has to be a specific reason for a referral, not just to do a check, so to speak. One other thing is when we used to recommend that at the autism center I was at before, a lot of parents wouldn't come in for the 3-year. They didn't feel it was necessary. So we really just want to make life easier for parents and families in that way.
Thank you all, and thank you, Dr. Bridges. This is such amazing information, and I think such a unique perspective that we've not really had outside of Dr. Drill. I mean, it's just so nice to hear all that you shared with us.